Good evening, all the aspirants. Here we have the speaker, Dr. Asif Iqbal, who is a HOD Respiratory Care and ECMO Services at Apollo Multispeciality Hospital, Kolkata. And the topic for today is Respiratory Pneumonia ARDS ECMO CCS session. Thank you, sir. You may take over.
Thank you for kind introduction. For the student who will appear EDIC Part 2 exam, so you definitely get one cases where patient having the pneumonia, and they will ask about all about the ARDS management and the ECMO management. Yeah. So this is a very important class, and those who are missing it, please they should take the recording. Fatma, please ensure. Okay. So now
Sure, sir.
my screen is visible.
Yes, it is visible. Perfect.
Okay. Yeah. Thank you. So the first vignette in the CCS, you will get the cases in a venient manner, and for the long cases, you will get 5 to 6 variant, and in a short case, you will get 3 to 4 variant. Okay, so variant nothing is a scenario. First variant, after giving the first variant, they will give you a little bit time, and after that they will proceed the case. Okay. So first being a 60-year-old man presented emergency department complaining of persistent right-sided chest pain and cough associated with productive sputum, yellow in color, and little bit hemoptysis. He was admitted to general medical floor for the treatment of community acquired pneumonia, and he has initiated ceftriaxone, azithromycin, oxygen through nasal cannula, and other supportive measure. By hospital, day 3, his respiratory status continued to worsen and requiring transfer to intensive care unit for hypoxic respiratory failure. On arrival in the medical ICU, the patient appeared dyspneic and desaturated on the NRBM 100% oxygen. Patient was started NIV support but continued to deteriorate on the NIV. Maybe this is a clear-cut scenario. They are wanting to ask about the ARDS. Yeah. But most of the time you will get scenario like that is community acquired pneumonia kind of thing. The patient having fever. Usually they give the old age patient around 55 to 60 years, and then fever, cough, little respiratory distress, and they presented to you. So what will you do? So then the question will start from like whether this patient need intubation or not. Means they are asking about the CRAF score, CRAF 65. It's like that. So this is a case where the community acquired pneumonia admitted in the floor with ceftriaxone, azithromycin, and day 3 patient further deteriorate, shifted to ICU and the NRBM. So the question from this scenario, they might ask, what is the differential diagnosis of your patient? What is your immediate management of this patient? How will you intubate this patient? What is your initial ventilator strategy for this patient? What is your limitation current volume definition for the ARDS? This kind of question. So first thing, if the question is differential diagnosis, so you have to tell about the what are the differential diagnosis in CAP or in a pneumonia. So it is a bilateral pneumonia with ARDS, bacterial or viral, though you have not received the X-ray yet. So you have to tell about that this is you are dealing with the case of pneumonia because cough and fever is there. So maybe the pneumonia migrated to ARDS. It may be the etiology may be bacterial or viral. And also this patient can have the topical illness like dengue, malaria, Krabs typhus. A lot of dengue patient, Krabs typhus patient, malaria patient, they can develop pneumonia. Then there might be a connective tissue disorder, Wegener granulomatous disease, congestive heart failure, interstitial lung disease, AEILD, or AECOPD can be there. So in that case, now the EDIC has been changed, the pattern, marking pattern has been changed. Initially, it was like that 5-pointer, 3-pointer, 2-pointer, 1-pointer. So if you give the correct answer, means what is they are expecting, you will get the 5 point. And nowadays is not like that. It's the all answer is the correct answer is the 1-pointer. So you have to be very precise and you have to give the all the data you have. Like in the diagnosis, you can say only it may be the community acquired pneumonia progress to ARDS or congestive heart failure, but you can wait. But no, the tricks is that you have to utter all the possible cause. So you might, you never know if you give only two answer and if this is two answer is correct, only you will get 2 marks. If you give the 10 answer, might be 5 answer is right and 5 answer is wrong. So remember in EDIC, there is no negative marking. Even if a practical exam is not like our Indian system that if you give wrong answer, it will have wrong impression. Yes, if you give very wrong answer, then it will create a wrong impression. But you have to give all the possible causes, which may be the etiology, okay, for the respiratory distress. Then the next question was in the variant. Next question was, what is your immediate management for this patient? So immediate management in this scenario, the patient is, if you see that patient on the NIV, in the NRBM 100% oxygen patient was started NIV support, but continuously deteriorate on the NIV. That means the indication is in the NIV failure. So you do not wait or you do not utter the HFNC, I will give the HFNC, I will wait for the NIV to settle down of the patient. No, you clear cut say you have to say that I will go for the mechanical intubation. So from the mechanical intubation, they might ask you question about how will you optimize your patient, what is the physiological difficult airway, what is the how you think that the intubation was easy or not. So remember the difficult airway is in the ICU, all the patient are under the category of the difficult airway because they are anatomic. There might be anatomical difficult airway or the physiological difficult airway. What is the physiological difficult airway? They might be on the inotropic support, they might be on the hypovolemic status. So when you are intubating, you are giving the sedation drug, there might be develop hypotension and cardiac arrest can be precipitated. So you need to optimize the patient. You need to optimize the volume status. You have to use this agent which causing very less a hemodynamic instability, like you can use etomidate as an induction agent. You can use remifentanil. And regarding the muscle relaxant, you use the rocuronium because you have a sugammadex for reversal agent. And Then you are putting the mechanical ventilation. They might ask about the what will be your ventilator setting. So you have to ask about the ventilators. You have to have the answer of the ventilator setting. Like the fourth question, that what is your initial ventilator strategy for this patient? So lung protective ventilation, moderate, high PEEP, open lung ventilation. I will use tidal volume as I will set tidal volume as per the predictive body weight. They might ask question about the predictive body weight. What do you mean by the predictive body weight? How you will calculate the predictive body weight? Then they might ask about your PEEP strategy. How will you set PEEP? What do you mean by the open lung ventilation? They might ask about the trial name. What trial support your open lung ventilation? So you have to utter this ARMA trial name. You have to know the recent development on this field. Okay. Then the question is, what is the limitation of the current Berlin definition? They might ask about the Berlin definition and the limitation. So current, the recent American College of Chest Physician, they have recently given the criteria of new diagnosis of ARDS, where in place of PO2 FiO2, they are using PO2 SPO2. SPO to FiO2 ratio, because there are lot of resource limited center where the ABG is not available in a third world country. Even in India, in the district level hospital, they don't have the ABG facility. So PO2, FiO2, you can't measure. But SPO2, every nursing home, every small setup, every hospital, they have the SPO2 facility. So that's why now the new amendment is the SPO2 FiO2 ratio. In the they have included in the definition. Now coming to the same cases, after intubation, you have done the X-ray and X-ray showing this. So chest X-ray post intubation, AVG is 80% oxygen, pH is 7.15, PaO2 is 67, PaCO2 is 56, bicarbonate 17, lactate 2, base X is 8. This is the scenario. So what is your next question? So the sub question related to this variant. Anybody can switch on your unmute yourself, and you can tell me the answer, the outline strategy. What is your strategy next after seeing this X-ray? What will you do next? Anyone can answer. No one. This is not exam, so you can tell if if anything wrong. Nobody will beat you. Nobody is giving you marks. At least you try to judge yourself. So outline strategy regarding that ventilation strategy. Once you have established the mechanical ventilation, now there is a question whether you will give sedation or not, whether you will give muscle relaxation or not. If you give sedation, what sedation you will continue in your ICU? What is your sedation protocol? What is the sedation holiday protocol? Why sedation holiday is important? This type of question they might ask, and they will ask about definitely about the neuromuscular blockage, whether you will use or not. So with to improve severe ARDS and refractory hypoxemia, what will you do for this thing? And they might ask what are the various methods for optimizing PEEP, the rationale of prone ventilation, what are the weakness of the procedure trial. First question, I have already mentioned that they might ask about the sedation holiday, and they are very fascinated about the neuromuscular blocking, whether you will use neuromuscular blocking or not. And if you use what is the recent evidence, the recent trial said that you can use the neuromuscular blockade for the first 3 4 days. It will improve the oxygenation definitely. But if you use long term, more than 7 days neuromuscular blockage, then there is a chance of development of the weakness, the neuromuscular weakness, that is called critical illness neuropathy. That's why it is recommended for first 3 days, 3 to 4 days you can use, but prolonged neuromuscular blockade do not. Then, then next question: how will you improve oxygenation to this patient on the ventilator? So I will. You already said that you will go for the open lung strategy, low tidal volume, lung protective ventilation. But if the PO2, FiO2 not improve, or it's less than 150 still, then you will go for the prone ventilation first. So then they might ask about what is the advantage of the prone and how it improve your oxygenation. The answer is it improve the VQ mismatch. It increase the surface area and more homogeneous ventilation is there. It increase FRC, improve drainage of the secretion. And then they might ask about a question on the PEEP. How will you set your PEEP? So first thing, your answer would be I will set my PEEP according to the ARDS net put net tables, and lower inflection point pressure volume curve will be your the starting PEEP, and stepwise recruitment or the de-recruitment depending upon the patient hemodynamic stability and the PO2 FiO2 ratio and the oxygen saturation. Next, Prosiba trial, which is a landmark trial for the prone ventilation. You have to know about the Prosiba trial and its limitation. So limitation, the weakness is it has been published in 2015, but patient not seen for the inclusion, raising suspicion of the selection bias in this study. Uh, Padma, please unmute. There is a lot of noise in the class. Please
Done, sir.
unmute. Some difference in the baseline characteristics of the SOFA score. All center were very experienced in prone ventilation, reduce generalizability. So these are the limitation. You can go through the placebo trial. And then they will give you the third variant, like patient had 3 cycle of proning, 16 to 20 hours of duration each, and he will continue to be 30%, 100% of the oxygen and saturated 90% on day 3 mechanical ventilation. Just a minute. So next is the question: outline factor would influence your decision whether or not to institute extracorporeal membrane oxygen support. And if you do, then they might ask about the indication of this patient. How will you, what is the inclusion criteria? What are the contraindication? How will you manage? How will you do cannulation, complication, everything about the ECMO they might ask. Okay. So you have to know about the ECMO, the everything. So the potential, the ECMO indication when there is a potential reversible cause for the respiratory failure, and when the mechanical ventilation duration is not important, but you are not able to maintaining the PO2, FiO2 more than 100, and if the patient is less than 60 years, no other organ involvement, or patient not in sepsis, you can be even in sepsis also, but it should be a reversible cause. Like If the patient has advanced malignancy, CNS hemorrhage, contraindication for anticoagulant, and irreversible cause of respiratory failure, then it is better to avoid ECMO. And you have to know about the Murare score. Murare score is the inclusion criteria where you will check the pH. Next is that regarding the what was the question? Sorry. So then the life-threatening complication of the ECMO, we will discuss about the ECMO in detail. I have a next presentation on the ECMO. So the complication of the ECMO is it can cause the LV distension, cardiac chamber thrombosis, bleeding complication, embolic phenomena, and complication related to long-term use of neuromuscular blockage. Already I have mentioned the long duration ventilation. It can increase the ventilatory day, long ICU stay because it causes the polyneuromyopathy, increased risk of Pacers ulcer, DVD, and sometimes causes winning failure. So next question is patient started showing improvement on ECMO. On day 10 of the ECMO winning was started and the patient was successfully decannulated on day 12. Patient continued ventilator dependent post ECMO decannulation. Now the question is what are the barrier of winning from the mechanical ventilation, list of predictor of winning failure, and list of potential cause of auto trigger during patient support ventilation, list of use of inhaled nitric oxide. So what are the barrier of winning from mechanical ventilation? The respiratory cause. So in this case, in this question, you can answer like that. This few patient related cause and few are the organ patient specified cause and the others cause like patient related respiratory cause, increased respiratory resistance secretion, or if the patient having the background comorbidity like asthma, COPD, they have a bronchospasm, cardiac related heart failure, or patient have if there is a triple vessel disease, then it can precipitate when you are doing winning, it can precipitate the heart failure. Metabolic and nutritional cause, the hypophosphatemia also causing muscle weakness, and neurological and musculoskeletal cause, neuromuscular musculoskeletal cause, the major cause is the weakness, the ICU muscle weakness. And second question is that list of predictor winning failure. One is chronic heart failure, weak calf, Apache 2 score is more than 2 on the day of extubation, failure to 2 or more spontaneous SBT, and other also lot like your here is the predictor. So diaphragmatic length, diaphragmatic thickness, diaphragmatic excursion, which directly proportionate to your interthoracic negative pressure development. So diaphragmatic weakness is a major cause of your winning failure. And if there is a neuromuscular weakness is there, yes. And if the patient having the neurological problem. And then next question is the list of use inhaled nitric oxide. So I don't know how many of use nitric oxide for a winning failure cases, but we use nitric oxide not routinely, but sometime in a refractory hypoxic patient in ARDS. Recently, I have used one patient, young male, 38 years. He was admitted with a bilateral pneumonia, frank ARDS, PaO2, FiO2 ratio is 110, and on after 3 prone ventilation, patient not improving. Then he has a দিবেন্দু দা আমি একটা ক্লাসে আছি গো
Sir, the mic is muted, please.
So I was in the winning failure, I think. It's not disturbance for a. So list of use, yeah, inhaled nitric oxide. Oh, in this case, in my case, the PO2 FiO2 ratio is the in supine position is around 110, and when I do proning, it is around 170. Then I have started the inhaled nitric oxide, and gradually the PO2 FiO2 ratio improve. So in a obese patient, my patient was obese, and the patient having the high PAH, pulmonary artery hypertension, then nitric oxide has a good role. But there is no mortality benefit till now. Whatever the evidence suggests, there is no mortality benefit. Acute hypoxic respiratory failure improve VQ mismatch the nitric oxide. Post cardiac surgery, pulmonary hypertensive patient having a good effect on the nitric oxide. It reduce the pulmonary hypertension, so it reduce the VQ measurement. Right ventricular dysfunction patient will be benefited. So this is all about my opinion thing. Next, I will take this class for the ECMO. Just hold on. So I'm stop sharing, and then I'm again sharing on the ECMO. Okay. So ECMO for beginners. Fatma, my screen is visible?
Yes, sir, it is.
Yeah. So next, extracorporeal membrane oxygenation overview. So what is ECMO? It is a basically extracorporeal of ox oxygen support system, and it bypasses the heart and the lungs. So by definition, it is two type. When you are giving the support for the heart, then you need to do the VV ECMO. When you are supporting the heart, then you need to do the VA ECMO, veno-arterial. And working principle similar like your cardiopulmonary bypass pump. And it is not a definitive treatment. It is basically bridge therapy for your destination. So a little bit about the ECMO circuit. So you just wait. This is my pen, and okay. I highlight. Where only pen is coming. Anyway, just follow this my pointer. So this is about your ECMO circuit. This one in ECMO circuit, there is a two cannula. One is called drainage cannula, other is called return cannula. The drainage cannula, when where from the blood from the body to come to the pump. Okay. So usually the drainage cannula is a blue color, or it's a black color of blood coming from the drainage cannula. The blood come to the pump, and pump to the, it goes to the oxygenator. Oxygenate. It is a this schematic diagram of the cardiopulmonary bypass system. So therefore there is a reservoir, but actually in the your ECMO there is no reservoir. So directly blood come to the pump, from pump to the oxygenator, where oxygenator is nothing but the filter where the gas exchange happen, and bloods get deoxygenated blood get oxygenated and carbon dioxide removed. There is a blender, and the blender, gas blender, there air and the oxygen come, and then it's come to the your filter. Okay. And after that, from the filter, blood goes to the heater or cooler system, then it's go to the, again go to the system in the body. So why heat and cooler needed? Because it is a continuous process, and the blood coming to the external circuit, so it's evaporating the temperature and losing the temperature, and if it is continued, then there might be a hypothermia. So to prevent this hypothermia, it's needed to rewarming of the blood before it enter to the system. Otherwise, there will be a coagulopathy. That's why a heater is required. Next, coming to your, it's not changing. Fine. So type of ECMO. What are the type of ECMO? Type of ECMO, one is veno-venous, other is veno-arterial, and hybrid type. So veno-venous commonly used for the ARDS. The blood drainage from your vein and return to the vein. Usually either it may be femoral or femorojugular. So drainage blood coming from the femoral vein, and return blood from the machine coming to the jugular vein. Or veno artery, or femoral means femoral vein to other femoral vein. And veno-arterial means blood coming from the vein and returning to the artery, usually do femoro-femoral in a VA ECMO, where you are supporting the heart in a cardiogenic shock situation. So then the drainage cannula in the femoral vein, and return cannula in the femoral artery, the same limb or the different limb. And hybrid thing is uses when the blood drainage cannula in the femoral vein, but the return cannula in the femoral artery, and also in the jugular or the other femoral vein. So where it is required in when you are supporting the heart and lungs both. So in a ARDS patients, we do lot of hybrid technology. In a ARDS patient, suppose you have started the veno-venous ECMO, but the patient developed hemodynamically compromised and patient developed cardiomyopathy, then you need to do hemodynamic support also, where you need this hybrid technology. So this is the schematic diagram of the VV ECMO or VA ECMO, and other devices you can use during the VA ECMO. So what is the clinical indication for disease patient where whom you will put the ECMO? One is the acute respiratory distress syndrome, ARDS. It might be the any cause. The main pathway is the ARDS, and where the refractory hypoxia is there, or be a ECMO in a acute cardiomyopathy situation, whatever the cause, or in a breathing therapy for lung transplantation or the cardiac transplantation and pediatric congenital cardiac disorder. So very important thing is about the initiation of the ECMO, cannulation and management of the SARS post-intubation. So initiation of ECMO, it's my unit. We have done this thing. So prerequisition of the initiation is well-oriented team, sterile field, ideal single peak, uncomplicated puncture for the peripheral ECMO. Why? Because you need to give the high dose of anticoagulant like heparin. So it is important you are doing in a single punch or a minimum hematoma you are doing. So it is better you do the line USG guided, and vascular surgeon is need to be surrounding, because in case of because it is a very big cannula, anytime there might be an injury in the posterior wall of the vessel, laceration can be happen, so somebody has to take care of that. And next important thing is that the prime. So priming is important of the circuit. Priming means your circuit should be filled up the normal saline with heparin. You can use instead of saline, you can use other things like blood or albumin, but usually the saline is preferred. These are the cannula. There's arterial cannula. Arterial cannula is narrow and shorter size. This big one is femoral, and this one is your usually femoral arterial cannula we use. It is a subclavian arterial cannula. And venous cannula is a longer size and little wider. This is femoral, this is jugular. Then most important thing, once you are doing cannula is a very simple things. Like you are putting the center line, you do a puncture, put the guidelines, then do serial dilator. The dilator, it is a little bigger and the wider. So do serial dilatation and then put the cannula. So then you have already primed the set. So you just connect the cannula with the circuit and wait for a few minutes. You start with pump centrifuge RMP is around 1,000. Then incrementally you increase the pump speed up to 3,000 or 3,500. And why what are the they might ask about the what are the different pump, that roller pump used in the cardiopulmonary bypass machine, and centrifugal pump is used in the ECMO. Why centrifugal pump? Centrifugal pump has causing less hemodialysis, so that's why it causing less hemolysis and less coagulopathy. And second is the important, when you have done the cannulation, next important thing is to check the limb about the perfusion, especially when you are doing the veno-arterial. So you are putting large cannula in the vein, large cannula in the artery, so distal perfusion disturbance happen. So you have to check the distal portion of the limb, the skin condition. If there is a insufficiency, there is a early mark of mottling, then you have to put the distal perfusion cannula also. This is same patient. We have done the veno-arterial ECMO, the drainage cannula in the femoral vein, and the return cannula in the femoral artery. So there is a distal flow deficiency. So we put another distal perfusion cannula sheath to perfuse the limb to prevent the ischemic complication. Again, this distal perfusion cannula. Then cannula position, how will you check? Once you have established the cannula, then you have to check the cannula position by radiography by echocardiogram, radiography by chest X-ray because it is a radio opaque this cannula. This is a distal cannula and this is the upper cannula, and you have to keep some gap between two, at least 10 centimeter. Otherwise, the recirculation will happen, so there will be no effective oxygen supply in the body. So that is very important to prevent recirculation. So you have to check the position of the cannula by X-ray or doing the echo. So the transesophageal echo is better. In the transesophageal echo, you can identify the position of the both the cannula. And next important thing about the anticoagulation of ECMO. So anticoagulation, why? Because it is a extracorporeal circuit, so there is a increased chance of clotting. So you have to make the filter alive. So you need to do some and take some anticoagulant measures to make clot free. Clot free ECMO run is a myth. There will be some clot, but you allow that much clot which will not disturb your filter function. So the importance is how you use the heparin when you are once you put it the guide wire, you give the bolus fast dose. You put it the guide wire and then you dilate it, and during dilatation you give the 50 unit per kg IV bolus and circuit prime with the fluid and the heparin. Then initial few hours post initiation, keep anticoagulant free, measure the ACT, and you keep the ACT between 140 to 200. Don't allow ACT to come down less than 140. So, how will you monitor your uh, what are the agent you can use? One is unfractionated heparin or direct thrombin inhibitor or low molecular weight heparin. I have no experience on the low molecular weight heparin, but there are some publication. You can use low molecular weight heparin in especially in a long-term patient who need long-term ECMO for patient waiting for the transplant. And what are the monitoring tool? Either you can do ACT, antithrombin 10A, or APTT you can measure depending upon what agent you are using. So APTT below target range, increase heparin dose. ACT advantage, you can do the bedside, but discrepancy factor 9, 8 deficiency, fibrinogen deficiency, or factor 13 deficiency, patient with lupus anticoagulant, the ACT will not give you the good result. Or anti-10, you should, if the when you are measuring anti-10, then reduce heparin dose if the target above the target range. So monitoring is very important. Monitoring means one is whether the ECMO functioning well, whether the oxygenator functioning well, and the console is functioning well. There is no scatter, and the cardiac output maintaining well. So first thing is the monitoring. Important is the color difference. So always drainage cannula is a deoxygenated blood, so it will be blackish, and the oxygenated blood, it will be red in color. So if uh, this color difference is there, you are happy that your ECMO is working fine. This is the scenario that both the color is same. So what to do next? So that means either your filter life is gone or there is a clot. So you have to change the filter, the lungs, artificial lungs. Usually it is happen after 3 weeks because the oxygenated life is up to 3 weeks, or if there is a clot is happening. So color difference is an important monitoring skill. Next monitoring is the coagulopathy, bleeding from the site of the ECMO, whether bleeding is there. So if there is a bleeding, then first check the coagulopathy, and second check the ACT also, and do the dressing and keep compressing bandage. Sometimes if you do 3-4 picks, develop hematoma, then there is a chance of development of the bleeding in a normal INR or normal ACT ratio. So it is important to notice the soakage. If the soakage is increased, then you have to take care of the bleeding part. And next, coming to the flow disturbance. One is this is the normal flow. Normal in the ECMO is a linear flow. If there is a flow disturbance is there, then you have to identify what are the cause for the flow disturbance and how will you take measure. The flow disturbance causes, one is the poor volume status of the patient or inadequate drainage flow, the kinking of the circuit, cannular obstruction. You have keep RMP very high in the centrifugal pump because what actually doing the centrifugal pump, it rotate and it create a negative pressure, and for this negative pressure help to drainage the blood. So if you keep very high RMP, then it creates very high negative pressure and the cannula in the vein. So venous wall is very thin, so it can collapse and cause the scattering or flow disturbance. So you have to look after all these things. And persisting intravascular volume depletion, post-cannular retroperitoneal bleed, GI bleed. If there is a persistent hypovolemia, then you have to find out the cause of the hypovolemia. And then other monitoring, the parameter look during ECMO runs. One is the color, then the pressure gradient between the uh, your artificial lungs, that is filter pressure gradient. Pre-filter and post-filter pressure gradient is a membrane pressure gradients actually, and heparin ACT. And also you monitor the flow pattern, and you also calculate the DO2 of this patient, and what will be your ventilator strategy during ECMO. Your examiner can ask. So in ventilator, first initial 5-6 day ventilator parameter FiO2 is as low as possible, PEEP is minimal, and keep eye on the plateau, and then monitor the VO2 and CO2. And once the patient settle down, the oxygenation is improved, PO2, FiO2 is improved, then gradually decrease the oxygen delivery, the DO2 of the machine, the blender, and increase the FiO2 on the ventilator. And when the minimum has 30%, and ventilator is able to maintain 50% of FiO2, then probably the patient timing for the winning from the ECMO. And winning from the ECMO is a art. Uh, so the advantage of is given organ support vitals for survival. Differences are not trained distributed shock, require multidisciplinary team, perfusionist, trained nursing, blood and blood product is needed. Does it can't require a team wide because need very close monitoring, vigilance, various compartments, centrifugal blood pump, oxygen circuit, cannula, console, blender, and the may require portalization the supplement which they require and physiotherapeutic rehabilitation facilities. So mobilization, other important cornerstone. So mobilization, routine mobilization, to improve the muscle power, or mobilization to patient for remove the monotonicity of the patient. This is physiotherapy of our pain. Sometime you need to mobilize the ECMO patient in the OT or in the CT scan suite. So you have to have dedicated team for mobilization. And the beauty of the new ECMO machine, which is a small machine, you can see in the 1971 when the ECMO used, how much bigger machine was there. So second important thing that winning from the ECMO, they might ask about how you will win. First, you check the parameters of your patient, the lungs parameter, the PO2, FiO2 improvement, and how much due toward the blender oxygen fraction, how much you can reduce. If you are able to reduce more than 30%, and your ventilator maintaining oxygenation by maintaining PO2 FiO2 ratio more than 200, probably the patient is ready for the winning. And gradually you reduce the RMP, the ramp of the centrifugal pump, and which reduce the cardiac output as well. Cardiac output means missing cardiac output. Then you gradually decrease the RAM and decrease the cardiac output and decrease the oxygenation, and check whether the conventional ventilator is able to take up the patient maintaining PO2 ratio, and how the sensor everything is the patient. If everything is all right, then you can remove the cannula. In venovenous ECMO, there is no need for the stitching or repairing the patient. You just give a patient and hold for 30 minutes, it will be okay. In arterial cannula, when you remove the arterial cannula, you need to have the vascular surgeon who will repair the artery. Otherwise, there will be a big hematoma and the bleeding might be patient can succumb. So that's all about your ECMO winning. So thank you all. And I have another presentation on the recent advanced management of the ARDS, but probably I will not be able to complete today. So I will request coordinator ma'am, if you can give one more class on this CCS topic, that's the recent advance of ARDS management, because they
Oh,
have to know everything about the ARDS management,
sure, sir.
because any one of you can get the cases on the respiratory, because it's a core subject of the critical care, so they might ask about all about the ECMO and all about the ARDS. So I will take another class probably this week, if you can allow me to, not this week, next week, if you can allow me or reschedule my CCS on ARDS management. Okay.
Sure, sir. Sure, sir.
So
I'll let you know.
I'm telling you the last exam, the cases story. So last exam, they have given the two scenario on ECMO. One is patient admitted with a community acquired pneumonia. Then they ask all about the community acquired pneumonia, the diagnosis, causative etiology, and what are the investigation you will send. Then what are the management strategy guideline? Uh, they all ask about the different scoring system, prognosis, and then the next variant, this patient develop ARDS. They ask about the ARDS management. What are the recent changes? Then the patient is severe respiratory failure. And on the mechanical ventilation, what will you do? Obviously, you will do proning. They ask all question about the proning. Then the proning failure, what to do? Then you have an option for the ECMO. And then they ask all about the ECMO, troubleshooting of the ECMO, everything. So in CCS, particularly in CCS, the vignette like go on. So those who are appearing this year exam. So Fatma, I need a list of students who are appearing this year exam. I will take classes when
Sure, sir.
I will give the focus on them. Yes, I will take the next class. Where I was, Fatma?
So the EDIC Part 2 students, aspirants' name who are appearing for this
Yeah.
semester. So,
So I will take special classes for last year's what are the cases has come. I will take class on this cases basis. Okay.
sure,
So
sir. I'll
they will
schedule
get
it
the
accordingly.
real cases. So every week keep one classes for the ED2 student
Sure, sir.
from my
Thank
side.
you. Okay, sir.
Okay. Thank you all. Thank
Thank
you
you all
all.
the aspirants for being with us.